Hello, my name is Jill Berry Bowen, CEO of Northwestern Medical Center, and your host of the NMC Health Beat Show, dedicated to discussing important and very interesting healthcare topics. Today I'll be talking to Dr. Greg Brophey of Northwestern Ophthalmology. Dr. Brophey is a board-certified ophthalmologist, and he's here today to talk to us about macular degeneration.
That's right.
Wow. I haven't heard a lot about that, so I'm glad you're here to let us know what it is, and is it called something different, or what is macular degeneration?
Well, thanks for having me, Jill. That's a good question, and that's actually the shortened term of that diagnosis. Really, the proper diagnosis is age-related macular degeneration, and so we often shorten that to macular degeneration. But unfortunately, it's all too common in our offices, and is a major cause of vision loss in people as they age.
So age, what age are we talking about, since we're all aging here? When should I be
true.
looking out for this?
It's relatively uncommon in patients younger than age 50. At age 50, it only occurs maybe in about 2 to 5% of people. Over age 70, it's much more common. Up to 30 to 35% of patients can be afflicted with the disease, and oftentimes people don't know that they have it.
So what percent of our population might we expect that would have that? Is it, how frequent is that?
Again, it's highly dependent on age. So over age of 70, you could expect up to 30 to 35% of patients to have the condition, and many of them don't know that they have it until they have an eye exam.
Oh, I was just going to ask you about the symptoms. I mean, it's not until an eye exam?
The symptoms are, unfortunately, patients would experience nothing that would be specific for the diagnosis. Many patients come in and simply feel they need to have an update in their glasses prescription because they don't see well.
Okay.
Other people experience very characteristic symptoms like bending of straight lines. If they're looking at a picket fence, the vertical slats of the fence might look bent or crooked. Some people may experience letters in words, certain letters being larger than others, and other people just simply notice dimness to their vision. So the symptoms are really nonspecific, and many patients come in feeling that it just simply they might need a new update in their glasses prescription. What complicates matters a little bit more is that it can only affect one eye and not the other. So with the unaffected eye masking the symptoms of the affected eye, that can certainly delay the diagnosis in some patients.
So does it move to the other eye, or just stays in the one eye?
Well, it's usually bilateral, meaning it can affect both eyes, but it can be asymmetric, which means that it can affect one eye more than the other.
Okay, wow.
But frequently, if patients develop severe vision loss in one eye from their macular degeneration, their other eye is considered to be at very high risk.
Okay, all right. And so how do you diagnose it?
Macular degeneration is diagnosed using an eye exam, or doing an eye exam. So in the course of an eye exam, a portion of the eye that we look at is the retina, which is in the very back of the eye. So if you imagine the eye being a tennis ball, if you break open a tennis ball, it's hollow on the inside. So what I'm looking at would be the inside of the eyeball. And the macula is the very, very back portion of the eye.
Okay.
So the eye is lined with a very, very thin tissue called the retina, and only a small portion of the retina is actually involved in the disease of macular degeneration. But unfortunately, that's the central portions of our vision. So if you can imagine looking at a clock on the wall, if you were to have macular degeneration of the severe variety, the central portions of the clock would be invisible, and you would only be able to see what would be around the outside.
Wow, fascinating.
Yeah.
So what about treatment?
Treatment depends on the stage of the disease. If we see a patient that has only early findings of macular degeneration, there's no guarantee that that patient's going to lose vision later in life. So the treatment would be really focused on close observation. I would teach patients some screening tools that they can use at home to carefully monitor the macular status of both eyes. And really we try to focus on prevention. There's really many different ways you can get macular degeneration. We think genetics plays a prominent role, but certainly health style is also very, very important. So patients frequently ask, what can I do to prevent macular degeneration? And really, one thing that you can probably try to do is eat a diet rich in green leafy vegetables. People always think carrots are good for the eyes, and they're probably not bad for the eyes, but really it's the green leafy vegetables like spinach, kale, the broccoli, those things are very, very good for you. And of course, avoidance of smoking is important. And if you have other conditions like high blood pressure, high cholesterol, those need to be optimally controlled as well, because those probably also play a role. So to get back to your question, in terms of treatment, the best thing is to help prevent it to come on if you can. And really, we can't fight genetics, but we can modify our behaviors. For patients that we see that have what I call high-risk features of macular degeneration, those patients can be recommended a vitamin supplement. And finally, patients that actually have severe vision loss from macular degeneration can get treatment, including injections.
So in the patient population that you see, what percent would you say come through your office that need to have some type of treatment because of this disease?
Well, fortunately, there's several different types of macular degeneration, and patients are usually aware of these. There's a form called dry macular degeneration, which is definitely the most common form, and then there's a form called wet macular degeneration, which only makes up about 10% of patients. It's the patients that have wet macular degeneration that need treatments. Only about 10% of my patients ultimately end up getting referred for that sort of treatment.
Okay. So any advice for the folks that haven't gotten to that 50 yet? Is it really about diet? Can we really prevent this, or is this just a natural course of aging?
It's considered a natural course of aging, and you know, you can't fully control what you have in terms of your genetics. You can't you can't really affect how those genetic traits ultimately get develop later in life. But again, prevention is really the key to a lot of disease, and avoidance of smoking, maintenance of optimal weight, blood pressure, and cholesterol management are really the best things for patients to do. The other thing I would advise would be, over the age of 65, this is certainly more common, and over the age of 60 or 65, it's probably advisable for patients to get an eye exam every year or two. And if I usually tell patients at their first eye exam, if I don't see signs of macular degeneration at age 65, it's still possible they could develop it later on in life, but that's a good foundation for moving forward, because patients will understand what to look for in their vision over future years.
Great, great. Anything else we should know about macular degeneration that the community should know?
I do. I think macular degeneration, many people are very afraid of the diagnosis because they think they're going to go blind from it. Macular degeneration almost never causes complete blindness. What macular degeneration causes is loss of the central vision. So what's frequently preserved in macular degeneration is the peripheral or side vision. So what we really have to advise patients is to, if they have the diagnosis and they end up needing treatment for wet macular degeneration, it's really more of a reassurance to make sure that they understand that they're not going to go blind. But frequently this involves a multi-pronged approach from many different types of professionals to get them rehabilitated. So we rehabilitate patients with severe macular degeneration by recommending special eyeglasses or special stand or handheld magnifiers to help them see. There's many different treatment modalities that we can recommend for patients. But that's the biggest thing I would want people to know, is that this does not mean it's going to lead to blindness.
Great. Good to know. Now, what about activities of daily living? I think about someone in their 70s potentially with this. What about driving? I mean, are folks with this able to, with corrective lenses, be able to drive, or, you know, how does this affect?
It's a great question, and many patients are afraid of losing their independence, as you know.
Exactly.
And it really depends on the patient. It's patient to patient dependent. Many patients that have dry macular degeneration, as I said, don't even know that they have the disease, and so are able to drive with the condition just fine.
Okay.
So it really needs to be approached on a patient-by-patient basis.
Okay, great. Okay, good. Well, that's reassuring. So you said this is about 10% of your practice. What makes up the rest of your practice? Because you have a pretty busy practice.
I do. My practice is a comprehensive ophthalmology practice, so I see patients really for a lot of different things. Many patients that see me have other diagnoses like diabetes, and so as a diabetic you need to have a yearly eye exam, because one of the things that diabetes can affect are the eyes. The other thing I do is cataract surgery. I see a lot of people that have cataracts, again another major cause of vision decline later on in life. I treat patients with glaucoma and many other eye conditions.
So talk a little bit about cataract surgery, since that is probably a larger part of your practice.
It probably is.
So what can an individual expect if they get diagnosed with cataracts?
Well, usually there's a lot of fear. Patients come in and are afraid to have surgery on the eye, and I totally understand that. So part of it is really reassuring the patient this is a very common condition and something that can be safely and expediently corrected in the operating room. But what I would tell patients is that cataract surgery is not uncomfortable. It's something that they're not going to be worried about or stressed during the procedure, because we can give medication through an IV to help them relax. And most importantly, their visual function will be improved, and it can really open up a whole new world. I've had many patients tell me they never realized their house was so dirty until they had cataract surgery. So it's a nice thing. And really what I tell patients is it really opens up a whole future for them in the future of great vision.
Interesting. Do you do anything with folks that are colorblind? When folks, do you see anybody? I only mention this is because I was watching something and talked about these special glasses that you can wear to correct color blindness. Do you see anybody with that, or anybody that has any concern about that?
I do, actually. I have many patients who come in that know that they're colorblind, and a lot of these are congenital forms of color blindness. So they'll come in, and through the course of an eye exam, they will bring it up and mention it to me. And when I do an exam on patients that are colorblind, their eyes don't look any different than anyone else's eyes do. But many of these folks that are born with a condition have simply adapted to their vision and don't know any other way of seeing other than how they see.
Yeah.
That's a great question. But these cases of color blindness are not treatable, of course.
Okay, all right. So you have more than just your ophthalmology job.
I do.
At the hospital. So tell us what else you're up to.
Quite busy. I'm fortunate to be on the administrative team at Northwestern Medical Center. My title is Executive Medical Director of Physician Services. So I play a very key role in coordinating and supervising our employed providers. And those providers are specifically in our outpatient practices. And it's a fun job. It's very challenging. Because I do work a full-time job as an ophthalmologist. So there's a lot of morning and lunch and late evening meetings, but it's great because, as you know, at Northwestern Medical Center, we are promoting an environment of excellence, and it's really nice to be able to interface with the docs and help them be the best that they can be. Yeah,
it's wonderful to have someone like yourself being on the executive team, because it helps us to really partner to make the right decisions for the future. So
that's
really appreciate your work. And of course, those that are busy, we just add more things because you're good at what you do. So
thanks.
So we love having you. So what else are you doing? Specifically, any recruitment for physicians, or you talked about overseeing physicians, anybody we can expect coming, or anybody recently joined our team?
We've had several great doctors join the NMC team just within the last couple of weeks. We've had Dr. Susan White join our addiction medicine team. We've had Dr. Stephanie Niter, a dermatologist, join our team, and Dr. Derek Chase, an orthopedic surgeon, join our orthopedics team. So it's been great to see young people come in with new ideas, with new vigor for practicing medicine, and we look forward to them being a part of our community for the long term.
Wonderful. It's great to see us growing
with
great providers. So 2016, you're going to be moving, possibly?
We are going to be moving. I think the date for our move will be in May of 2016. We're moving to a bigger facility for our ophthalmology practice, because our practice has really outgrown our current space. We're moving to a second floor suite, which adjoins our dermatology clinic. So our practice will be right next door to dermatology in the Northern Valley Eye Care building on Fisher Pond Road. So it'll be a brand new facility with new equipment and lots of exciting stuff happening up there.
I know, you are just on the move.
It'll be great to partner closely with our optometry friends downstairs and offer a convenient space for our patients.
Sounds perfect. Well, our time has flown, so thank you very much for being
Thanks, Jill. It's great to be here.
Terrific guest on macular degeneration. We've talked about a lot of things today, so thank you so much.
Thanks, Jill.
I'm Jill Berry Bowen, CEO of Northwestern Medical Center, and your host of the NMC Health Beat Show. Thank you for joining us, and take care of yourself so we can slow down this aging process.